This is for Mary. We do get our children enrolled in the family care process, but they continually, as they come up for re-enrollment, they're lost. They don't do it properly. I don't know what to say, but it falls apart.
I'm so glad you asked that question because I was going to mention that in my presentation. It's a problem. Here's what happens. You have this like big bucket of kids, right? And you do all this work to outreach them and bring them in, and then they fall down the outside at the bottom of the bucket. So we're trying to work on what we call now administrative re-enrollment, which would mean that rather than making them re-enroll, we're working on like a postcard that we can send to the person saying, if all of your information is the same, you will stay in the program. If it's not, contact us. That's what they do in other states, because the idea is not to enroll people and then have them drop off. It's a real problem. It's costly to us. It's very disruptive to the families. So the reason that hasn't happened in the past is because there's always been this focus on we don't want people to keep this benefit if they don't need it. But we're thinking that we were better off just re-enrolling people, assuming like they signed something saying it's all the same, and then we just keep on going with them. Because in fact, most families don't change income levels all that much in a year or two period. So I'm so glad you asked that question because that's one of the key strategies we're using this year is administrative re-enrollment. We're trying to roll that out this year.
Hi. I just have a comment and a question on the access issue that you were talking about. I'm a primary care provider and also I'm an ER physician locally in Trenton, and we have actively tried to recruit our patients to come back into the state and be transferred to children's hospitals within the state. Unfortunately, they're being refused by the children's hospitals, not because of service not being available, but because the physicians don't want them. And it's happened even from Jersey City, where I work in the ER there too, and I tried to transfer a patient who was under custody, and I was told by the children's hospital, no, we won't take them if they have a police escort. So these are things that we have to deal with, on the primary care side and also on the side of the hospitals as community-based hospitals. And I think, I'm very happy that there is an organization now that's working towards, solving these issues. But I think you do need to go out to the pediatricians and find out what the issues are.
Talk so that we better understand what those challenges are.
Yeah, but generally, the biggest point is that when we're referring a patient in and we know the service is available, there shouldn't be an excuse from the children's hospital saying that we can't take the patient because the private doctor doesn't want to take them.
Is anyone in New Jersey working on, or is there any plan to have requirement that you take Medicaid patients, or is that like beyond the pale? There's private practices that will not.
I'm not aware of any plans to do that, and I don't know why that is, but I'm not aware of that, and I don't know if you can force people to take Medicaid because of the rates are very low, from what I understand.
Well, does any place do that? Any place in the country? You must take a Medicaid patient.
That's a good point, though.
That may be a part of the need of really doing a needs assessment as to what is the reality of access to care for children in our different Medicaid programs. And I think this is something, Deb, you and the Children's Hospital have been wrestling with as we look at our scorecard. Maybe some of the subspecialists are being counted twice. They're listed at two different hospitals, but it's really only one orthopedist who is servicing those. And then within that practice, and this is the drill down we've never done, and it's something Dr. Notterman and I have talked about, is how many of those practices have caps in order to stay alive financially at the poor reimbursement rate that we're at with our various Medicaid products. Many practices cap the percentage of Medicaid patients they'll take, and or are they only seeing Medicaid patients at one particular site, like at the teaching hospital orthopedic clinic once a month, but therefore they're seeing other patients or privately insured patients. We need that data, I think, in order to really determine how to break down these barriers and improve access. I'm sorry.
Can I just ask a question in that context, which is what are the opportunities to raise rates in New Jersey, and do the current rates constrain Medicaid children's access to services that are required under the state plan?
Yes. Yes, yes.
You know, that's a good question, and yes, traditionally that has been the problem. And I know that recently we did raise fees on fee-for-service side for children for Medicaid. Just in the last few months, we did that. But that has been a persistent problem. Is that the Medicaid reimbursement rates in New Jersey are historically very low, and that does contribute to access problems significantly. So I think it's something that constantly has to be addressed.
So that's number 1C below. By insurance, I mean public insurance. Family care, as a potential problem.
One of the problems that we face as part of the issue of availability and access related to specialties is that many of the pediatric subspecialists are attached to the children's hospitals, the institutions that are partly located here. And some of those institutions are financially stressed, and because pediatrics is such a heavily based in ambulatory services, it's one of the first things that sort of gets hit because they don't provide significant margin to the hospital's mission. Is there any way that the state can take a look at, as hospitals tend to cut back, whether or not pediatric services are affected? Because I know that a number of the hospitals are actually, and already have implemented changes in that area.
Are you saying changes in the pediatric area?
Yes.
Yeah.
Certain hospitals are already making cuts to reduce pediatric services because of the financial stress that the overall institution has.
Mm-hmm. Yes, that's also an issue that my division, which is Department of Human Services, we don't do the hospital side, but that is done by Commissioner Heather Howard, which is DHSS. And I know what they do is they do spend a lot of time looking at hospitals in distress and also looking at hospitals that are reducing their services. So if that is an issue, it should be being addressed with that division, which is DHSS, because what we've been doing is we've been trying to figure out what are we going to do when hospitals close. Like when Muhlenberg closes, what have we lost in terms of beds and space, and what are we going to do about that? And we spend a lot of time in the state trying to reconfigure healthcare systems just for that very reason. So certainly that's something we want to have brought to our attention, because it's, we're very concerned about that. Because access is an issue, and we've seen several hospital closings in the last 2 years.
I heard information technology mentioned a few times today, and when I looked at the map from the Commonwealth assessment, the states that that are doing fairly well happen to be involved in a lot of, they use their public health information systems. They've got populated immunization registries, and that are not just silos, but are integrated systems, so that they have child health information systems. And how can we in New Jersey, we've got the immunization registry is mandated, but not until 2011. We have a wealth of information in New Jersey. We have a wealth of data that doesn't get turned into information to really improve the quality of care and to be used for accountability and for quality improvement. So I think that needs to be part of the conversation, is how to make that happen so that we can improve and also reduce costs, so that even as something as simple as childhood immunizations, that children are not over-immunized, which is costly, and we're not inappropriately using costly vaccines. So I think that has to be part of the discussion.
Ruth, I'd like to chime in on that, and Bob, you can chime in too. I think we have some opportunities here as different IT systems are evolving here in New Jersey. For instance, with the children who are DCF involved, the New Jersey Spirit System, and some of us don't like to hear that word, but there are opportunities in that now for tracking medical indicators, immunizations, lead levels, even developing somewhat of an electronic medical record, at least for the kids, when they're systemically involved. And now with the evolution of nursing units in each of the individual DIFAS offices, with theoretically somebody who can coordinate the care for the children who are at that time systems involved with DIFAS, we're moving in that direction in that system. One thing I think a lot of people might not know about, the kids who are in the juvenile justice system who are actually adjudicated and in the system, not just passing through. They have evolved a marvelous electronic medical record that I would urge anybody who's into looking at systems for coordinating medical care for systems-involved kids to look at. And that was something I was totally unaware of until I did my little sojourn with the state. So there are models there that I think we need to become more aware of and find out how we can efficiently use them.
And we do know that there's a lot of data in the state. And in fact, we do have a shared data warehouse in the state, in our division. And we're working right now on we've populated that data. We have data from DCF, we have data from Medicaid, we have encounter data, and we are trying to pull that all together. And we're actually trying to build some kind of capacity so that we can actually have like a kid record, a record of a kid, so that we would know this is a DIFAS kid and they're also enrolled in Horizon and they've also had immunization. So we've actually have made a lot of investment in that infrastructure, and we're working on producing something from it right now, in fact.
One of the areas, I think there was a great presentation about showing how New Jersey has really made a lot of progress in providing specialty services. We still are not close to having really all the services, and including some fairly basic services. And one of the problems we face, and I believe these are fairly across the board in all our institutions, or some specialties are residing in the private sector. An example of such would be ENT. In the middle of the night, it's very, very hard for hospitals like what Rad is talking about from Trenton, where they may not have pediatric specialties, where we have specialties in New Brunswick. It's still hard for us to provide those cares, those type of specialty cares at our institutions. The problem we see is when we talk to our colleagues are primarily reimbursement. Even though the fee-for-service certainly has made an improvement in the last few months, most of these children are residing in the managed care. And managed care, unless there is some leverage from the Medicaid or government or legislative action or some sort of, it's going to be very, very hard for us. I mean, we would like to provide, and our colleagues are there, but it's just not feasible for us to get that model up and running for in the state unless reimbursement to specialists is improved.
Yeah, and I think that's a good point. I also think I'm glad you pointed out that we do have 805,000 people in Medicaid managed care, and most of our children in Medicaid are in managed care. So the rates are obviously very important, the networks are important, and we have diminishing number of people in fee-for-service. So you're absolutely right.
I'm just curious that all of our presenters have mentioned the barrier of cultural language, immigrant status, so on and so forth, but no one has provided any statistics on where New Jersey is. Now, I think we all know New Jersey is probably one of the most diverse states in the whole entire union, and I'm just wondering, does anyone know where New Jersey stands in terms of promising practices or approaches to increasing that access to the very diverse group of individuals that we are seeing on a daily basis in practices and all over regarding medical needs?
Well, we do have our family care application. I think it's available in many languages. If you go online and it'll say we can provide a translator for you for I think it's over 100 languages. But it is an issue, and I'll tell you why. Here's an example. We just had yesterday. I was meeting with the FQHCs, and I talked earlier about presumptive eligibility or getting people to apply online. And they said one of their problems is that the county workers that come out and help them are stationed in, say, hospitals, are not bilingual. So in the FQHCs, a lot of their patients are not, English is not their first language. And so to sit with somebody who doesn't speak English and go through a process of trying to apply online is very difficult and time consuming. So it's a continuous issue on many levels, the reading levels and the translation levels. But we also are doing research about which kids we think are not going to be able to sign up for insurance because of the immigrant status.
Can I just comment here? And I think it has bothered me that the silent elephant in this room is our immigrant children. And I think first we have to think about the ideologic change that has to happen in this country, as we need to move towards universal health insurance for everybody who's in this country, much as all the European countries have done. You know, if you're in England and you're a recent immigrant and you have a baby and you have 3 other children with you, all of your children are covered for the primary care. That's a huge ideological change that has to take place nationally and in our mindset and then in DC, so that then as we're trying to deal with universally covering children here, we don't have this silently not talked about many thousands of children population, which are called the siblings of the immigrant children who were born in this country. And I think for those of us who have worked in primary care settings at our teaching hospitals, et cetera, this ridiculousness, this is the environmental barrier that we really can figure out and solve, that happens night after night, day after day, as we're seeing families in clinic. The baby was born at our teaching hospital and is on Medicaid because they're a U.S. citizen. The 2 other children, 8 and 12, walked across Texas and now have been reunified with their mother. And now without charity care being accepted in many of the outpatient clinics, you know, we used to see those children for well care, but I couldn't give the vaccines from VFC to those non-documented children because they're not Medicaid eligible, et cetera. If we are really going to do this right, all children in this country should have the same package of coverage. Vaccines should be federalized, and for us pediatricians, wouldn't it be nice to have one code for your administration fee and one code for each of your vaccines that you give, and vaccines, which we know of a 10 for 10 return for the healthcare dollar, are given to every single child in this country at the same rate and on the same schedule and in the same medical home. So I have to put that 35,000-foot view here. We are going to continue to have a mess in this state by carving out this population, especially of the undocumented siblings of kids who are on Medicaid and having these multiple different services for people. But that's where we are right now.
I agree with that. I totally agree with that. We're constrained by federal law, what we're allowed to do.
And that's what needs to change. We educate every immigrant child in this country. They have access to the same educational system as kids who are born in this country. That's the ideologic change that needs to take place. Why can't we take care of their health?
No, I totally agree with that. And I think most of our department would agree with you on that.
Yeah.
Okay, we've covered a lot of territory since I raised my hand here. Maybe I can make a few very, very quick points. Number one, I remember Stephen Hawkins once said that the difference between the fate of the dinosaurs and the human race was NASA, or will be NASA, or something like that, in terms of our being prepared for some cataclysmic event. And I draw the analogy to our present system, which is bad and getting worse and everything. And I think if the only ultimate answer to this is information technology. Everything else we talk about is really quite secondary, because we will not have the number of personnel to have hand-to-hand contact with patients that we'll ever need. Our facilities are going to get more complicated. The flow of information gets more complicated. So it really is information technology. Fortunately, Governor Corzine and the legislature put together a committee with Commissioner Goldman from Banking and Insurance in his office to try and integrate all those aspects across the state government that deal with healthcare. Any department that has a toe in electronic medical record or data transmission is being looped into this. And I think it's a fabulous, fabulous effort. We need to get our hospital systems on board as well, but that is ultimately the answer. Without that, nothing is going to succeed. Also, with our system of children's hospitals here and everything, it's so vitally important to support that. We've heard a lot of anecdotal stories here and everything, but the bottom line is when we hemorrhage patients to Philadelphia or to New York City, not only do we hemorrhage the money that goes with them, but also the talent and techniques that we need to maintain here in New Jersey. You cannot have just one ENT doc in a hospital and expect them to be on call 7 days a week. You need 3, 4, you need a critical mass of specialists and patients to sustain those departments. As we continue to hemorrhage patients across the rivers, we're never able to sustain that. And why is that necessarily a bad thing? If you think back to Dr. Redlander's presentation where he had the pickup truck stuck in the mud, it all comes down to transportation. So much of our state does not have the ability to run back and forth to a Philadelphia or New York City if they have a seriously ill child that's going to be there for days, weeks, months. It's a multi-hour transportation trip. It's expensive. They have other children. They may be a single parent. We have a responsibility to the people of New Jersey to make sure that we have these child care facilities available to them in a reasonable proximity. It's our responsibility to do that, and we have to keep working towards that.
I have a question for Dr. Perrin. Can you comment on the Cuban model as a team, the team approach where it's kind of built different? Cuban model built different from ours, where I think they may be deteriorating a bit, but what they had was like a family doctor for every 600 people or something, and then they had the specialists were clustered.
It's a great question. I can't comment really on the Cuban model, but let me just say that one of the interesting things about comparing the U.S. with our neighbors up north and our friends across in England and France and so forth is that the U.S. and Canada have the highest percentage of GDP going into health care. We're top, of course. Canada is second. And then you get across and go to Europe, and it's actually substantially lower. And one of the reasons it's lower, as Barbara Starfield has pointed out well a number of times, is that there is a substantial and consistent cross-the-market investment in community-based, team-based primary care. It varies quite a bit from country to country. So in Great Britain, you have the health visitors. Now, admittedly, they're trying to Americanize the health visitors so that they won't be quite so universally accessible as they've been. But up to this point, when Lady Di had her kids, the health visitor knocked and said, "Do you need any help understanding about breastfeeding, and can I help you?" and so forth. There's a universally accessible system, a preventive community-based care, highly integrated into the rest of primary care. So in France, they have Centre Maternel, which provide, again, a basis of primary care at the community level for everyone. You get paid to get your kids immunized in France, unlike here. In Scandinavia, they have a series of community health centers that are based on physician-nurse partnerships, basically, universally available. In Canada, they don't. They have universal health coverage, but they don't have a similar system of community-based primary care that is found in all of those other countries. In the U.S., we certainly don't. Okay? And, I don't want to say that all of our extremely high expenditures are based on that, but I do believe that is a substantial piece of it. We're not investing in community-based preventive services that would make kids and families healthier. So I know that's not the Cuban model, but it's a model that may be even more applicable to New Jersey.
Yeah, a question, actually perhaps a comment. Just as New Jersey seems to have more school districts per square foot than any other place on earth, it also has a rather large number of children's hospitals. And while the care in our children's hospitals is good, having so many hospitals prevents the ability of a hospital to gain the size needed to hire additional specialists and develop the expertise needed to create real niche care. And until we address the fact that we have not regionalized pediatric care in this state and that we have children's hospitals a block or two apart from each other, we are not going to ever compete with New York and Philadelphia. I can say that now because I don't work in any acute care hospitals, by the way.
I'm not kidding you, Dr. Costello.
Well, what I've done, obviously, is put some random thoughts down. based on what we've heard today. I urge you, if you have other thoughts or communications you want to see end up in our final report, email. My email is on several of those papers, but I'll write it over here. And I will see that they get transmitted to Mr. Keevey, our writer. Sorry, Mitch. Okay. Did I type it wrong? We can't spell those down here in Princeton.
So Dan, who's going to get this report, and who's it going to go to, and in what format?
Rich has a well-integrated system here.
We will, number one, produce this on video here. It'll be on our website, which we'll send out and address that anybody can access it. And then we will prepare a report for all forms, I would say, 3 or 4 months.
How do we get
So how do you...
We will be able to. Well, everybody who has signed up and been here gets on our mail.
making the efficient?
We just sent out 2 or 3. We just outlined one on eminent domain and one on fair housing. So it depends upon the topic. After the conference is over, we get it all put together. What we want to ask everybody. No, I just want to. It will be on the website. You go to our website. Well, of course, we're happy to host this forum. This is 3 at 3, so we'll finish temporarily with healthcare as far as the policy research. You're on our mailing list, and you probably should have gotten at least one announcement. We're doing an interesting forum on November 7th that we call Financial Crisis is in the Region. And the first panel has to do with the anatomy of the mortgage crisis. The second panel has to do with the crisis surrounding municipal finance. Our lead speaker is Susan Wachter, who is a professor of finance and real estate at the Wharton School. Our luncheon speaker is Alan Slider, professor here at Princeton, former vice chairman of the Federal Reserve Board. And after him, we have Congressman Leach, former chairman of the Congressional Finance Committee, I think it was, and he's going to talk about responsibility of Congress in this mess. I guess he can talk about it because he's no longer in Congress. But he's a former congressman from Iowa and is on the new faculty here. So you'll have that announced. That's our next major forum here at the Apollo. So thanks for coming. Enjoyed working with Dan. He was an active and persistent.
Chapter 11 is actually national.